What's up, everybody? In this video, I want to go through the 5 digital workflows that can transform your practice in 2024. And again, this is after looking at a bunch of the doctors that have been training with us for a couple of years, just looking at the ones that I feel like have made the biggest difference. And again, if you're new to us, our recommendation is you take one at a time. But if you're still kind of trying to figure out where to begin and where to start, look at these 5 and then prioritize accordingly. And then I think you can start hitting them one at a time. Without a doubt, the number one workflow is virtual articulation and case planning. We tend to attract doctors that are comprehensively focused. And for us to be able to gather for photographs, to be able to do all the things that we would normally do in the analog world in terms of how we would take pictures and analyze them, we can then put all this data on a virtual articulation or virtual articulator and to look at centric, look at slides, do all the things that we would normally do just so much faster. We can still treatment plan the same way, thinking about biologic stability first, functional stability second. We can then plan for our restorative or our prosthetics. So again, this is a case that involves some Invisalign and some fairly conservative veneers. So you would begin with that process of straightening teeth prior to a restorative type phase. Again, this is a case that had some expansion, opening up some space for laterals. So again, so far all digital and how we're doing the orthodontics and looking at our ClinChecks. You can see the spaces open up on the laterals here and a little bit broader arch form. And then the cool part comes when we start doing phase 2 records and we can really start to see where things are going. We can align that photograph and cut away the teeth and pick the teeth that we're going to do our waxing on. We can line up our scan right in the patient's head. We can start doing our design and position it in the patient's head, and then bring our virtual articulator in and make sure everything's lined up accordingly. This has just become standard of what you do, and something that would take a couple of days in the analog world, we can do very, very rapidly with much better outputs with more accuracy. So being able to design those edges and really get clear about where we want teeth to be and be able to pick a tooth form from the tooth library specific for the patient. We still have the same capabilities to, let me back up one. We still have the same capabilities to close the articulator and to see where the slides are, to see where those first point of contacts are and equilibrate. It's a little bit different, but still the same process. So we can make CR and MI the same if you like to work in centric relation. And then whatever disclusion pattern you want, whether it's anterior guidance or group function or whatever you're working through, we can develop that. And then our design can be sent to Model Builder. And again, if you have the capacity to print in-house, you can send it to Model Builder. Or you could send your file to a lab to have it printed for you if you're not quite there yet. But being able to take your design through Model Builder and to really start to see beautiful contours that can be then printed. They'll then go into a wash station for a little bit and then cured. But that anatomy, that tooth form from the library of some of the best technicians in the world, we can then create matrices from that, prep our case, put provisionals in that mirror those contours that we worked out. And then once we're happy with our provisionals, we can scan the provisionals and the laboratory can superimpose the provisional model right over our prep model, which will then allow us to utilize that prototype to communicate precisely where our edges are going to be and envelope of function and all of that. So virtual articulation and digital design, utilizing a fully digital workflow, I think is number one. Okay, and again, I think if you can get comfortable, get that workflow in place where you're mounting your models and doing the designs, following the videos and really working through the process of learning the buttonology will allow you to be able to do much better and much more efficient restorative dentistry. And it also allows us to communicate to patients in a way that is really unprecedented. The second workflow, I think, is looking at printing precision orthotics and night guards. We have the capacity and the training to teach you to do all of these, whether it's the dual arch deprogrammer, the programmer that I do for short term, lower Tanner full arch appliances, and looking at upper full arch Michigan type appliances are all options for us. And again, the software Splint Studio rapidly, and I'm talking 15 or 20 minutes, will allow you to design all of these once you get pretty good at it. Again, if you're not printing yet, you can do the design. This is the way I did it for years, and I would send it over to Bayview, and Jordan at Bayview Dental Lab would print them for me. I do like using the key splint material. This, again, cured properly, and this is, I'm hearing some people with certain printers and curing units, it might not feel quite right, but this should be a very rigid material that's a little thermoplastic. But the process is going to be that you're going to scan, you're going to mount and design, you're going to print, you're going to polish, and you're going to deliver. So again, scanning is basically the same as anything else. And the Splint Studio, I think, is one of the most simple workflow software buttonology things to learn. And so that's why, early on, I really encourage doctors to do this, because they get to use the articulator, they get to work out excursions. It's things that are going to help them when they move on and start doing more sophisticated designs later. So I'm a fan. Again, as you move on and you start getting good at the design aspect of it, you may get into printing. Again, this is the key splint material in a Sega Max printer, and we can do singles or we can do multiples. And getting into this, at least in our practices, several of the other doctors out there that are doing this, definitely saves thousands of dollars by the end of the year. If you're doing any amount of night guards or TMJ orthotics, this can get very, very expensive, depending on the level that you're doing. And I'm finding that these appliances with the key splint are some of the most accurate and just the best orthotics, most comfortable orthotics that we are seeing. So highly recommend you jump onto this one. Workflow number 3, and again, this is an advanced workflow for doctors that are comfortable doing more complex cases, but looking at when you start to alter vertical dimension to print or have the lab print, or you can print little toppers in the back of the mouth to change vertical without having to prep their teeth. This is a great example of an erosion case where we had some restorative dentistry to do in the front of her mouth. She was wanting to open the bite but not prep those teeth initially. You can see the teeth definitely need a little bit of length and they need to be brought out. We're going to do the same two-dimensional planning to figure out where the teeth would go, looking at the photographs. And again, this is a little bit of older case before I had the software, so I was utilizing the lab, and I was communicating with them specifically where I wanted to go, and they were doing the wax up in the front of the mouth, kind of giving an idea of how much taller the teeth will be in the back with those little arrows. But you can see where my lower incisal plane is going to be. Upper incisal edges are similarly communicated, looking at photographs. They do the digital design. This was an ExaCAD, which is another excellent software. But seeing the length changes there from incisal edge up to free gingival margin. simulating about 1 millimeter of crown lengthening as well as 2 millimeters to the incisal edge. These are all things that we did in the analog world. But digitally, we can now look at the overbite-overjet relationship in the space that we would like to increase in the back. And what the lab can do for you is, rather than do a wax up, they can print little onlays. We call them toppers. And in our practice, we actually can print these ourselves now and teach you how to do it once you have a printer. But designing these is simple, and then delivering them isn't that difficult. We do every other one. So this is an example of the first bite there, or actually it's the second bite and the second molar, missing the first bite, already bonded. And then the middle one is just etch, some sort of bonding resin that's cured, and then that little veneer, that little onlay is delivered just like a veneer. You can use a little 2 millimeter tip. You're going to get rid of the resin first, tack it down, floss it, and cure it the rest of the way. So these toppers are an excellent digital workflow. Whether you're making them or the lab are making them, they're just like little extensions to the teeth. And you can see before we prep the anteriors, the posteriors are all bonded, and you can see how they blend pretty well in the back. And this is a while ago. This is just printed, milled PMMA back then. Now we're printing with either the Onyx in the Sprint Ray or the in the Asiga or the Accurita. We can use the rodent sculpture material, both resin ceramics, so they're going to last even longer. But here's again, there's the prep. You can start prepping, do veneers in the bottom, crowns on top, and then once the provisionals are all in, this is provisionals in the front, toppers in the back, illustrating the increase vertical. Nice view of the toppers in the back with the provisionals up front. And once we're here, we've just kind of turned it into an anterior case. So there's pre-op, provisionals, and the finals. And this concept of doing the case 4 times in our mind, in wax, or in this case, a digital design, where we're doing a wax up front and toppers in the back. We're doing the provisional prototypes next, and we're doing the case the 4th and final time in porcelain. This can all be dialed in accordingly. And again, toppers are just an excellent way for you to segment those more difficult cases that maybe you don't want to prep all the teeth at once. Maybe the patient can't prep all the teeth at once. But putting a little hat on the tooth, as Ian Buckle likes to say, is an excellent way for us to take a really complicated case and get it done in a very, very good way. Workflow 4 is digital dentures. And I'll say right up front, in our practice right now, I still rely heavily on the lab to do a lot of the design work, although that's one of the goals this year, is to at least be able to do our prototypes in-house. Charlie Wall is the dentist who's the resident expert. As a dentist, they're doing pretty much everything in-house. And of course, Lee Culp and their lab are phenomenal at this. But here again, being able to take a patient that is severely broken down, I would recommend that looking at immediate dentures. They're actually the easiest ones to begin with. When patients are edentulous or have bad dentures, there are workflows for that. But starting with immediate dentures is great because you can usually get a good enough scan of the palate and up at the height of the vestibules to be able to make a good prosthesis. And you're going to be putting soft line in it anyway. So get great photographs. You want to start there. A lot of times we're looking for one key tooth to hone in on. In this case, tooth number 8 was in a decent position, maybe a little bit back. So we're going to lengthen it out, bring it out for a little bit. But once in the software, the laboratory can extract the teeth. Because they can work with a ghost scan, they'll always have a representation of where the teeth were. And what I love about the digital denture workflow is we're basically setting up a case almost like we're doing a wax up. So we set all the teeth up first. We can always see where the teeth used to be. And then we also can mark the borders of where everything's going to be. And the software will just fill in the space between the apical aspects of the teeth and where the ridges are to create the bases. We're going to print our prototypes, and we'll print the bases in a color. They can also be stained. We'll print the teeth in one solid piece. In the finals, we still feel like the milled may be the strongest and best option, although that might be changing. And then just understand that if you do this or the lab does this, because we're in two pieces, there is a bonding material or a bonding process that will allow you to essentially glue the teeth into the record base, and then things can be finished and polished. But what I have found is that this has been just an unbelievably successful process. And I feel like one of the reasons that makes it so successful is because, we're used to doing 28-unit wax-ups off of photographs and figuring out where teeth go. And so in the analog world, we're sawing teeth off the dies and teeth can get moved around. And I think there's a little bit more of a potential for things to get off. I also am becoming a big believer in the fit of these things. A lot of the analog workflows, like post dams and things, were there because things shrunk a lot and didn't really fit well. So this is superior. This is a superior way. And as you get further into the workflow, Charlie's section on the digital dentures that's still being built has all the steps in there. And I think you're going to find that this is just an excellent way to do removable prosthetics, better than in the analog world. The last workflow we're going to look at is number 5, prosthetically driven surgical planning. And I'm just going to take you through a pretty simple case here of somebody who started with missing buys. She had ortho as a kid and they pulled teeth but couldn't quite close all the space. So we went through some Invisalign and opened the space back up, made sure that, from our CTs that we could go ahead and definitely get teeth in there, implants in there. And so here again, we're going to start with great photographs. We're going to go ahead and get our data in there. And just like before, we're going to create an order form. We're going to import our scans, mount models like we would normally do, clean up the models. Any little attachments can be removed, any light prepping. And again, before we start planning implants, we want to know where the teeth are going to go. And so one of the best, I think, reasons to do this is I don't want to guess. And if I can do a design that shows me precisely where the teeth are going to be when they're veneered and precisely where they're going to be from a restorative standpoint when I replace the tooth, I can then take this design and import it into my implants planning software. And that could be the Implant Studio if you have that for 3Shape. This is an example of using RealGuide. So I can basically go through all the steps that I would do to optimize my design from an aesthetic and functional standpoint. Then I can open up RealGuide, import my CBCT, import my wax up as I'm doing here. And again, that's data stacking, right? That stacks one on top of the other. I can then place my implant and get it exactly in there, kind of thread it in there to make sure I've got my 2 millimeters between the roots. And then I can get it placed so it's coming right through the anatomical crown of where my final restoration is going to be. This allows me to then create a surgical guide in RealGuide. Very simple process. It's going to get that position like that. I'll create little windows so I can see where the cuss tips are. Put her name on it. and then we have a guide. So this allows me now to see where the little cylinders are going to, or the implants are going to go. And then that guide can be printed either in-house or it can be sent to a lab. We print these in-house now. And again, then we get the drill report, which is going to go with our kit. But I think that, having guides, having the ability to do surgical guides in-house, it certainly allowed me to recognize the cases that are going to be simple, that I don't need to refer. And again, that's revenue that is kept within the practice. And what we find is that our plan and what ends up with where the implants go is extremely accurate. So, with that, what I want to just remind you is that Lee and I's mission here is to help dental teams and laboratories transition to 100% digital workflows while maintaining the sanctity of sound aesthetic, occlusal, biologic, and tooth-by-tooth structural principles. And we're going to do this through great education, coaching, and consulting experiences. So again, look at these 5 workflows. I think you'll find that if you take them one at a time, pretty soon it's just going to be part of what you do. So I hope you enjoyed this one. Good luck, and I hope to see you online on an online lecture or in a coaching session soon. Good luck with the videos.